1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's,
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
You know, when a mechanical pump fails, it's usually a pretty straightforward problem, like a pipe bursts, the pressure drops, and, well, a plumber just patches the leak or replaces the motor. It's just simple physics, right?
Right, yeah. You fix the brake and you restore the flow. Very linear.
Exactly. But when you step into the world of human hemodynamics, specifically a failing heart, that simple plumbing problem turns into this massive systemic biological rebellion.
That really does. I mean, it is the absolute definition of a physiological death spiral. The human body, it just does not handle pump failure gracefully. In fact, it basically panics.
And today, we are stepping straight into the ICU to look at a condition that puts, 6.2 million American adults into that exact spiral. Welcome to today's deep dive. We are looking at heart failure.
Yes, but specifically through the intensely focused lens of an elite critical care intensivist and nursing instructor. We're applying the 80-20 rule here.
Right, the Pareto principle. We are aggressively filtering out the noise to give you, the listener, the highest yield clinical understanding, because the stakes here are just massive, aren't they?
Oh, totally. This syndrome, where the heart simply cannot pump enough blood to meet the body's oxygen needs, it's projected to affect over 8 million people by 2030.
Wow.
Yeah. It is the #1 reason for hospital admissions in adults over 65. It drains like $30 billion from the healthcare system annually. And, you know, when these patients crash, they crash hard and fast.
Okay, let's unpack this, because to save a crashing patient, you have to clearly visualize the failing physiology, right?
Exactly. As an intensivist or a strong ICU nurse, you have to trace the pathology step by step. You look at the trigger, the physiologic change, the body's compensation, and then finally the decompensation.
So starting at the beginning, the trigger.
Right. The trigger is almost always some form of myocardial injury. We're talking about decades of chronic hypertension, severe coronary artery disease, or, you know, a massive myocardial infarction that literally kills off a section of the pump.
So the heart muscle is either physically damaged or it's just exhausted from constantly pumping against a really high pressure.
Yeah, exactly. And that leads to the fundamental physiologic change, which is a drop in cardiac output.
And since cardiac output is just stroke volume multiplied by heart rate, if that stroke volume drops, the tissue perfusion just plummets across the entire body.
Yes. The actual amount of blood pushed out with each beat is completely inadequate. And this is where the compensation phase begins.
The panic phase.
It's the panic phase, right. So the kidneys, they are highly sensitive to blood flow. When perfusion drops, they don't actually realize the heart is failing.
Wait, really? They don't know the pump is broken?
No, not at all. The kidneys just assume you are bleeding out in a desert or severely dehydrated. So to save your life, they activate the RAAS system, the renin-angiotensin-aldosterone system.
Ah, right. So they release renin, which triggers that whole cascade, resulting in angiotensin II.
Exactly. And angiotensin II is a massive vasoconstrictor. It just clamps down on the blood vessels.
And then you have aldosterone in the mix, too.
Right. Aldosterone signals the kidneys to frantically retain sodium. And as we know, where sodium goes, water follows. The body's sole goal here is to just increase preload.
To fill up the tank to restore pressure, basically.
And simultaneously, the baroreceptors in your aortic arch, they sense the low arterial pressure.
So they sound the alarm to the sympathetic nervous system, right?
Yes. Flooding the bloodstream with catecholamines like adrenaline and noradrenaline. This immediately spikes the heart rate and forces the heart to squeeze harder, which increases contractility.
I always think of the Frank Starling law here, you know, like a rubber band.
Oh, that's a perfect analogy.
Right, because if you stretch a rubber band just a little bit, it snaps back with more force. So by retaining all this fluid, the body is deliberately stretching the ventricle, hoping for a stronger snap to increase that cardiac output.
Yep, that's the goal.
But if you take a rubber band and overstretch it chronically, like day after day, it completely loses its elasticity. It just becomes a loose, floppy, ineffective pump.
Which brings up a paradox that is completely wild when you think about it.
Yeah.
The body's own natural survival mechanisms, you know, the adrenaline, the kidneys hoarding water, the massive vasoconstriction. These are actually the exact things that end up killing the heart.
Wow. Wait, so the things meant to save us are destroying the pump?
It is a devastating evolutionary blind spot. I mean, you have a heart muscle that is already injured, already starving for oxygen. And the body's response is to whip it with adrenaline to force it to run a marathon.
Whipping a dying horse.
Exactly. Meanwhile, angiotensin II is clamping down all the peripheral blood vessels, drastically increasing the afterload.
So now this dying, starving pump has to push against incredibly high resistance, all while basically drowning in the extra fluid the kidneys just forced it to hold on to.
The workload is insurmountable. And this increased afterload and oxygen demand, they force the heart to undergo pathologic ventricular remodeling.
The heart literally changes its physical shape to survive.
Right. The ventricular wall either hypertrophies, becoming super thick and stiff, or it dilates, becoming all stretched out and spherical instead of its normal elliptical shape.
Which perfectly explains the two main types of left-sided heart failure. So you have HFrEF, heart failure with reduced ejection fraction.
Yes, that's a systolic pumping problem where the ejection fraction drops below 40%. The rubber band is overstretched and totally weak.
Right. And on the flip side, you have HFpEF, preserved ejection fraction.
Exactly. That's a diastolic filling problem. The ventricle has remodeled to become so thick and stiff that it physically can't relax enough to fill with blood in the first place.
But both pathways just lead to total disaster.
Oh, absolutely. And keep in mind the anatomy of the plumbing here. Left-sided heart failure backs fluid up into the lungs because the left ventricle can't clear the blood coming from the pulmonary veins.
While right-sided heart failure, which, well, is usually caused by left-sided failure anyway, backs fluid up into the systemic venous system.
Right. That's where you see the swollen liver, the ascites in the abdomen, the severe peripheral edema in the legs, and the jugular venous distension, or JVD, just bulging in the neck.
Okay, so we understand the chronic remodeling in the baseline patho. But what does it look like when those fragile compensatory mechanisms finally snap?
That is when things get critical.
Let's bring us to the bedside. You know, when the patient hits the ICU doors in acute decompensated heart failure, or ADHF.
ADHF is a high-stakes medical emergency. The pulmonary venous pressure spikes drastically.
And that pressure physically forces fluid out of the pulmonary capillary beds, right?
Yes, it pushes it into the interstitium of the lungs, and finally it floods the alveoli. This is pulmonary edema. The patient is quite literally drowning in their own serum.
Wow. Imagine walking into that room as the nurse. What are the subtle early clues before the code alarms start blaring?
Early on, you really have to look closely. You'll see unexplained fatigue, a mild tachypnea, and a hallmark symptom called paroxysmal nocturnal dyspnea, or PND.
PND, right. That's when they fall asleep lying flat, and then all that fluid pooled in their legs redistributes back into their vascular system.
Exactly. Over a few hours, it overloads the heart. They wake up in the middle of the night in a sheer panic, just suffocating, throwing off the covers, needing to stand up just to breathe.
That sounds terrifying. And if that isn't caught, they progress to the classic signs.
Right. They develop orthopnea, meaning they need to be propped up on 3 or 4 pillows just to sleep. You'll see obvious JVD.
And if you put your stethoscope to their chest,
you'll likely hear an S3 heart sound. It's often called a ventricular gallop, and it is the literal sound of fluid sloshing into a ventricle that is already dangerously overfilled.
Oh, wow. But when you start seeing the late signs, I mean, that's when you are moments away from intubation, right?
Absolutely. The respiratory rate shoots over 30. They're using every accessory muscle in their neck and chest just to pull air. Their lips are turning cyanotic.
And then you see the absolute hallmark, the pink frothy sputum.
Yes. It is a terrifying visual. That is serum and red blood cells being pushed into the alveoli and literally whipped into a froth by the sheer mechanical effort of the patient gasping for air.
To manage this, I know intensivists categorize the deterioration hemodynamically, like based on congestion and perfusion.
Right. We look at whether they are wet or dry and warm or cold. Most ADHF patients present to the emergency department in what we call a wet and warm state.
Wet and warm, meaning they are deeply congested, they have pulmonary edema, so they are wet.
Yes, but their cardiac output is still just barely high enough to perfuse their organs, so their skin remains warm.
Got it. So the true nightmare scenario is when they transition from wet and warm to wet and cold.
Exactly. That transition means the patient is getting worse fast. Perfusion has just dropped off a cliff.
So what are the vital trends there?
The heart rate might be racing to compensate, but the MAP, the mean arterial pressure, is falling. Urine output completely stops because the kidneys are no longer getting blood.
And their neurostatus.
Their mentation changes rapidly. They become restless, agitated, or confused simply because their brain is being starved of oxygen. Their extremities become cool, ashy, or mottled. They're entering cardiogenic shock.
Now, in our sources, there is this fascinating ICU pearl that completely subverts what you might expect during an assessment. It's a classic exam trap, too.
Oh, I know the one you mean.
Yeah, the absence of lung crackles on a stethoscope does not rule out acute decompensated heart failure. I mean, how is that even possible if their alveoli are literally filling with fluid?
It's a brilliant, if deceptive, example of chronic physiological adaptation.
Okay, break that down for us.
So in patients who have lived with severe heart failure for years, their bodies slowly develop incredibly robust, high-capacity lymphatic drainage in the lungs.
Like an industrial sump pump.
Exactly like an industrial sump pump. Even when pulmonary pressures are dangerously high, that sump pump can temporarily sweep the alveolar edema away fast enough to completely mask the sound of crackles on auscultation.
That is wild. You might hear clear lung fields, but the patient is still in severe heart failure.
Right. You cannot rely on just one clinical sign.
So, okay, you've recognized the clinical picture of a crashing patient. We need to confirm it and immediately initiate the ADPIE nursing process, right? Assessment, diagnosis, planning, implementation, and evaluation.
Yes, exactly.
What are the highest yield diagnostics here?
The absolute most critical lab is the BNP, or NT-proBNP.
That's the hormone released by the ventricular heart muscle when it is physically overstretched, right?
Spot on. If it's elevated, you have volume overload. Plus, an echocardiogram remains the gold standard for visualizing ejection fraction and chamber dilation.
And what if you are in the ICU with a pulmonary artery catheter in place?
Then you will see a severely elevated pulmonary artery wedge pressure, or polyupy. Normal polyupy is about 6 to 15 millimeters of mercury. In a crashing ADHF patient, it can easily spike up to 30.
Wow, double the normal limit. So the diagnosis is confirmed, impaired gas exchange, and decreased cardiac output related to volume overload. Now we hit the implementation phase, the priority nursing actions.
And this is where we rank interventions. First, next D, then.
Right. And if a patient is drowning from the bottom up, I imagine the very first thing we do doesn't even involve a medication. It's purely positional. You sit them straight up.
Immediate high Fowler's position, preferably with their feet dangling over the side of the bed.
It uses gravity as a medical intervention.
Yes, by sitting them up and dangling the legs, you deliberately pool blood in the lower extremities. This instantly decreases venous return, which is the preload, to the right side of the heart.
Buying that drowning left ventricle critical seconds to catch up without being slammed by more fluid.
Exactly. You're physically manipulating hemodynamics.
Okay, so gravity's working. Next, we need to address the hypoxia and the fluid in the alveoli. We apply oxygen, but specifically BiPAP is a total game changer here.
BiPAP is crucial. It delivers a high concentration of oxygen, but more importantly, it provides continuous positive intrathoracic pressure.
Which acts like an invisible hand, basically.
Yes, physically pushing the fluid out of the alveoli and back into the capillaries so gas exchange can actually happen. Plus, that positive pressure in the chest compresses the vena cava, further dropping the preload returning to the heart.
So gravity and positive pressure from the BiPAP buy us a few minutes, but we haven't actually removed any of that excess volume from the body yet. We need to hit the kidneys.
Which is why your then action, your next immediate move, is to administer Fabry-loop diuretics, primarily furosemide.
And as we push those diuretics, we enter the evaluation phase of ADPI. Like, how do we know these interventions are actually saving the patient's life?
You watch the trends continuously. You want to see a massive, rapid increase in urine output.
And on the monitor.
You want to watch that pulmonary artery wedge pressure drop back down from 30 toward that normal 6 to 15 range. You want to see the work of breathing relax, the dyspnea resolve, and the oxygen saturation climb back to baseline.
Okay, so the airway is secured, positioning is optimal, and the diuretics are flowing. But in a severe crash, we have to chemically manipulate the hemodynamics even further. Let's look at the ICU pharmacy.
This is critical.
We know diuretics are first line to drop preload, but they come with an immediate monitoring priority, don't they?
They absolutely do. Furosemide doesn't just pull water, it aggressively washes out potassium and magnesium.
And as a critical care nurse, you have to monitor those electrolytes constantly.
Yes, because a sudden drop in potassium in a patient with a failing, irritable heart is just a guaranteed recipe for lethal ventricular dysrhythmias.
Right. So once we are managing volume, we often turn to vasodilators, like IV nitroglycerin or nitroprusside.
Exactly. Nitroglycerin primarily dilates the veins, which drops preload, but nitroprusside is a heavy hitter.
It dilates both veins and arteries, right? So it drastically drops the afterload as well, reducing the resistance the heart has to pump against.
Yes, but hanging a nitroprusside drip creates a very tense environment in the ICU because of a major safety alert. It requires extreme vigilance.
Right, because of what it breaks down into.
Exactly. Nitroprusside is highly potent, but as it breaks down in the bloodstream, especially at high doses or over prolonged infusions, it produces thiocyanate.
Which is literally cyanide.
Yes, you can inadvertently cause cyanide toxicity. The nurse must constantly monitor for unexplained altered mental status, profound metabolic acidosis, and deteriorating renal function while that drip is running.
Scary stuff. Now, what if the patient is sliding into that terrifying wet-cold profile we talked about, where cardiac output is plummeting and they are losing perfusion entirely?
That requires escalation. We might reach for positive enotropes like dobutamine or milrinone.
These drugs chemically increase the contractility of the heart, they increase the squeeze, but honestly, that feels like a double-edged sword.
Oh, it is the ultimate double-edged sword. Think back to the core pathophysiology we discussed. The heart is already starving for oxygen.
Right, so by pushing an inotrope, you are whipping a dying horse.
Exactly. You are forcing an exhausted muscle to work even harder, which dangerously increases myocardial oxygen demand. They are strictly used short-term in EDHF as a bridge to stabilize the patient.
Now, I want to contrast those acute crisis drugs with the chronic maintenance medications, the ACE inhibitors, the ARBs, Entresto, and beta blockers.
Right, the long-term tools.
Because these are not for the acute crash. These are designed for chronic neurohormonal blockade. They chemically block the RAAS and the sympathetic nervous system to stop the adrenaline and stop the vasoconstriction.
Which eventually halts and even reverses that pathologic ventricular remodeling over time.
And this brings up arguably the most critical ICU pearl and a classic exam trap for nurses.
Oh, yes. The beta blocker rule.
You never, ever initiate or increase beta blockers during an acute decompensated volume overload crisis.
Never.
Because beta blockers are negative inotropes. They naturally decrease heart rate and decrease the force of contraction.
Right. And if you administer a negative inotrope to a failing pump that is already struggling to move a massive fluid overload out of the lungs, you will instantly send that patient straight into wet-cold cardiogenic shock.
You just kill the pump completely. You have to wait until they are euvolemic, meaning their fluid volume is normalized, before touching the beta blockers.
Precisely. You hold the beta blockers until the acute crisis is completely resolved.
But what happens when the failing physiology entirely outpaces the pharmacy? Like, what if the diuretics and the vasodilators just aren't enough?
That is when the ICU team escalates to mechanical circulatory support.
And the engineering behind the intra-aortic balloon pump, the IABP, is absolutely fascinating to me.
It really is incredible. The IABP uses a principle called counterpulsation to mechanically reduce the heart's workload while simultaneously increasing its oxygen supply.
So a catheter with a long, sausage-shaped balloon is inserted through the femoral artery and threaded all the way up until it sits right in the descending aorta.
Yep. And it inflates and deflates in direct opposition to the heart's natural rhythm.
Wait, so it inflates when the heart is resting?
Exactly. During diastole, when the left ventricle is resting and filling, the balloon rapidly inflates. By taking up space in the aorta, it displaces blood backward into the aortic root.
Oh, wow. So this forcefully perfuses the coronary arteries, feeding that starving heart muscle a massive dose of oxygenated blood.
Yes. And then, milliseconds before systole, right before the weakened left ventricle is about to squeeze, the balloon rapidly deflates.
That sudden disappearance of volume creates a literal vacuum in the aorta, right?
Yes. It drastically reduces the afterload so the weakened left ventricle can slip the blood out into the body with almost zero resistance.
It is a phenomenal bridge to recovery, but the nursing care has to be incredibly intense.
Very much so. You have a foreign object sitting in the largest artery in the body, so you must continuously monitor for embolus. Also, the mechanical smashing of red blood cells and platelets against the balloon can cause severe thrombocytopenia.
And balloon migration is a constant high alert risk. Like, if the balloon shifts upward, it can occlude the left subclavian artery. As an ICU nurse, how do you catch that?
You routinely check the left radial pulse. If it suddenly disappears, the balloon moved up.
And if the balloon shifts downward, it can occlude the renal arteries, so you'd see a sudden drastic drop in urine output.
Exactly. And, if the IABP still isn't enough to stabilize them, the final escalation is ventricular assist devices, or VADs, and ECMO.
Those machines essentially take over the pumping action entirely, serving as a bridge to the ultimate intervention, which is a heart transplant.
But even a transplant is just trading one set of severe problems for another.
Right, because to prevent rejection, the patient requires lifelong, intense immunosuppression. Because of that, the massive risk of infection becomes the primary cause of death in the first year post-transplant.
The management is undeniably complex and fraught with complications, but you just have to remember the alternative is 100% mortality.
Right. Well, we have covered a massive amount of ground today, moving from the microscopic cellular level all the way up to mechanical heart pumps. Let's synthesize this complex physiology and ICU mechanics back into a cohesive, actionable picture for you at the bedside.
Let's do it.
Picture walking into a patient's room and piecing this all together.
Right. So if you remember only 5 things, if you consolidate everything we've discussed into a clinical mindset. First, recognize the core pathophysiology. Heart failure is a pump or fill defect that is lethally exacerbated by the body's own neurohormonal death spiral, the RAAS and sympathetic nervous system forcing ventricular remodeling.
Second, watch for the key assessment findings. If your patient reports orthopnea, shows JVD, and has a weight gain of 3 pounds in 2 days, you are looking at the hallmarks of dangerous volume overload.
Third, anticipate the most dangerous complication. That is, acute decompensated heart failure progressing to pulmonary edema and ultimately wet-cold cardiogenic shock.
Fourth, know your priority nursing actions blindly. Immediate high Fowler's position with legs dangling, apply oxygen or BiPAP, and get them on continuous ECG and vitals monitoring.
And finally, anticipate the most important treatments. 4V loop diuretics are your primary weapon to clear acute volume overload, while ACE inhibitors and beta blockers are your long-term tools for chronic survival and reversing the remodeling.
So to give you that unified one-sentence clinical picture, if you see a patient with sudden extreme dyspnea, orthopnea, JVD, and pink frothy sputum, think acute decompensated heart failure with pulmonary edema. Immediately sit them upright, apply O2 or BiPAP, and prepare to push IV loop diuretics while monitoring their potassium.
That is the exact mental model an intensivist uses to save a life.
It fundamentally changes how you look at the human body's resilience, doesn't it?
It really does.
Which leaves us with a lingering, almost philosophical question to close this deep dive. We've seen how our own evolutionary survival mechanisms, the adrenaline meant to help us outrun a threat, the fluid retention meant to save us from bleeding out, are what ultimately remodel and destroy the feeling heart.
It makes you wonder, at what other points in medicine is the human body its own worst enemy, aggressively trying to save itself today while practically guaranteeing its own demise tomorrow?
Definitely something to think about the next time you hear a heart monitor start to race.